Good morning. Thank you very much for attending this meeting punctually. Let's start. Item 1 on the agenda, election of chairman and deputy chairman if required. I'd like to consult members whether or not we need to re-elect the chairman of this panel. Not necessary. What about the other 3 members? All right. Thank you very much for your support. The second question is whether or not we need a deputy chairman. Not necessary. All right, so that's it for item 1 on the agenda. Papers. Legislative Council brief on Voluntary Health Insurance Scheme and the background brief have already been distributed to you before the meeting. Today we are mainly here to meet with deputations and individuals to listen to their views. Please invite the deputations and individuals to come into the conference room. And also please invite the officials to come in. Apart from panel members, all other members of the LegCo have been invited to this meeting. Mr. Wong Kok Heng, thank you very much for your support. 2 individuals will not be attending but have submitted their written comments. Is Mr. Leung Wai Shing from Eastern District Council, as well as the Association of Western Medicine Practitioners. Will the Bureau Directors come in? Good morning. $26 times 3, 78.
知道。早晨。
Okay, 各位早晨，咁啊好。Good morning. Thank you very much for attending this public hearing of the panel on health services, Subcommittee on Health Protection Scheme. I think all of you speak Cantonese. Anybody will speak in English or Putonghua? All right, in front of you, you have the microphone as well as your earpiece. Channel 0 is floor, Channel 1 Cantonese, Channel 2 English, Channel 3 Putonghua. Your remarks will not be protected by the Electoral Powers and Privileges Ordinance. That means you have to be responsible for your own written and verbal comments. In a moment, I'll give each of you 3 minutes to speak. Please be succinct in your remarks. If you cannot finish, you can submit your written comments before or after the end of this meeting. We have 26 deputations today, so initially I'll give you 3 minutes each to speak. We should have ample time for today's meeting. If you're interested, if you have time, you can stay on and have direct discussions with the Bureau Director after members have asked their questions. Without further ado, Let me invite the first deputation to speak. New People's Party, Mr. Nkatri. Oh, not yet arrived. So number 2, Oiman Estate Residents Union, Mr. Ma Hei Pang, their community officer. Good morning. I'm representing Oiman Estate Residents Union. I'm Ma Hei Pang. I'd like to raise a number of points. First of all, we support this voluntary health insurance scheme, particularly the standard scheme. Let me cite an example. In Oiman Estate, we have a 70-year-old Kai Fong who took out insurance some years ago, thinking that she would be able to enjoy her twilight years in peace. But recently, the insurance company told her that she is a high-risk person and will not have her insurance policy renewed. So what will happen to her? This indicates that the existing insurance regime is insufficient and imperfect. So we welcome this voluntary health insurance scheme, particularly the standard scheme. That is, renewal is a must. If the scheme can be launched in future, even though the government is to protect those who can afford health insurance, we should also be concerned about those who cannot afford the scheme or do not know of the scheme. So first of all, those who cannot afford the scheme. Usually these are grassroots with no financial ability to take out health insurance. They'll turn to the public sector for medical and healthcare services. Now in future, after implementing the scheme, will the hospital authority have sufficient manpower to maintain the existing level of services to provide for the grassroots? Well, some members of the public will shift from the public sector to the private sector. So Dr. Koh should review the manpower level. Secondly, those who lack information, they may not know this voluntary scheme. I hope that in this regard, the administration can work on communication. You should step up publicity such that those who lack information will have more information. Then we won't have a recurrence of the flu situation at the moment. Then more people will get information. Thank you. Next, Mr. Ngan Man Yu, Kwun Tong District Council Member. Thank you, Chairman. In principle, I don't oppose the voluntary health insurance scheme, but I have a number of worries. First of all, the scheme is to target inadequacies in the private insurance sector. Just now, this gentleman said that for the high-risk persons, the elderly, and those who are engaged in high-risk work, they cannot take out insurance. And some elderly persons have to pay a very high premium. Now, in this voluntary scheme, they're covered. Transparency in policies as well as premium will offer more protection. But tax concessions proposed may not serve as sufficient incentives for members of the public. So eventually there may be an imbalance in the market. Secondly, as our population ages, we see that for those in need of healthcare services, particularly those chronically ill and elderly with slight diseases like cataract, have risen in number in recent years. The original intention of the scheme is to pass certain cases to the private sector such that the public sector will concentrate on emergency cases. But is this voluntary scheme sufficient to offer incentives to shift the public from the private sector, from the public sector to the private sector? Thirdly, about hospitalization, at the moment, some people take out such insurance through their employers or organizations. The government has proposed a transitional arrangement, but is that enough to encourage the public to take out their own insurance? And then fourthly, for the $50 billion of public money to encourage people to take out health insurance, it's not mentioned in the paper. So is this consultation content different from that of the past? Or will the $50 billion be placed in other heads of expenditure in the public sector or under this voluntary scheme? Fifthly, this scheme has to rely on the private sector. I understand that there will be another consultation exercise for the private healthcare facilities. But the two schemes are interrelated. If all these worries cannot be resolved, I have some worries about the implementation of the scheme. Next, the Lion Rock Institute, Mr. Lo Ming-hin, their research assistant. Thank you, Chairman. Well, perhaps today we're talking about medical reform. Maybe I should ask you a question first, whether or not you have thought about this. For a certain place, what is the objective of medical reform? The ultimate objective of medical reform, what's it? Is for the patients in that place. Then let me ask you, if the medical system is for the public of that place, why is it that we've never been introducing voluntary doctors? At the end of the day, this scheme is for the government to subsidize Hong Kong people to consult private doctors. In overseas countries, if I need to go to an overseas jurisdiction to seek specialist care, or if a certain drug cannot be bought in Hong Kong is unwilling to introduce doctors from foreign jurisdictions. A few years ago, we got this distribution of $6,000. If we do not address the supply issue, then it's useless to inject money endlessly into the system. Hong Kong's medical system ranks second in the world. Well, why is this happening? It's because all along the Hong Kong government has been refusing to introduce foreign doctors. I have 30 friends studying medicine elsewhere. They're in famous universities in the US and the UK. They studied in famous medical schools. But they cannot come back to Hong Kong to practice. They're also Hong Kong's permanent residents. If we can introduce foreign doctors and competition, then we may not need any subsidy from the government for consulting private doctors. We may be able to afford those doctors ourselves. So this scheme is not for locals, unless you tell me it's for protecting local doctors, not local residents. Next, Democratic Alliance for the Betterment and Progress of Hong Kong, Mr. Ip Man Pan, the Deputy Spokesman of Health Services. Good morning. I'm Ip Man Pan, Deputy Spokesman of Health Services of the DAB. We've been discussing this issue for a long time. In the first consultation exercise, we discussed medical financing, and this time we're discussing Voluntary Health Insurance Scheme. The government would like to maximize the use of resources. For this public consultation, the DAB is supportive. We don't oppose a Voluntary Health Insurance Scheme, but I'd like to raise 3 worries. First of all, the original intention of medical reform is that our aging population will add to the need and cost of medical services. The government would like the public to turn to the private sector for such services. However, this voluntary scheme is just one more protection for the public. But for services and charges of our medical services, members of the public will still trust the public sector more. So this scheme won't attain streaming.
Secondly, although the administration projects that starting from 2015-16, the shortage in manpower shortage in the healthcare sector will gradually ease. However, the remuneration for private healthcare professionals can far exceeds that for the public sector. So there will be a more serious situation when doctors turn from the public healthcare system to the private sector, and the situation will only worsen. with the implementation of the Voluntary Health Insurance Scheme. As for the 12 principles set out in the VHIS, those who are not covered by insurance in the private sector, but those who are affordable, those who could afford insurance could get coverage, and we welcome this. However, on the whole, the premium will go up, and the risks of claims will also increase. About the high-risk pool, as said by the other deputation just now, the administration has not mentioned the $50 billion earmarked for the high-risk pool in the past. So it's questionable whether the government could really pay the excess. So we have to be very careful, and we also need to instill confidence in the minds of the public by offering tax concessions so that more members of the public would go for the VHIS and use private sector. Next, Ms. Tam Kim Lin from Hong Kong Federation, the Federation of Hong Kong and Kowloon Labour Unions. Thank you, Chairman. About the consultation document on voluntary health insurance scheme, private health insurance will be more transparent in terms of the charges and fees, and there'll be better protection for the high-risk groups. To some extent, this is beneficial. However, having read the consultation document, we do have some concerns. So I'll raise the concerns here for Secretary's consideration and see how you can follow up on these issues. For example, on the operation of the high-risk pool and the independent insurance authority, how the operation should work, and how you can increase the incentive of the voluntary health insurance scheme. And also on group policy or group hospital insurance. Well, I'll elaborate on these points. On the issue of high-risk pool, well, there are minimum requirements, and different individuals of the high-risk group could take out other plans. But there should be a definition on what high-risk groups refer to prevent different definitions adopted by different insurance companies, so that nobody will be turned down. And also within first year of implementation of VHIS, all ages will be eligible. However, starting from the second year, only those aged 40 or below will have guaranteed acceptance. However, it is very likely that within the first year of implementation, the public may still need time to know more about the scheme, and they may not be able to make up their mind as to whether to take our policy or not. We hope that the age limit could be relaxed. And on the high-risk pool, there is no clear guideline on the setting of premium under the scheme, and the full compensation could be made starting from the fourth year. And we are concerned whether the high-risk pool would be dried up eventually. And the administration, therefore, should draw reference from policies that in the private sector so as to ensure adequate protection. As for the independent insurance authority, we understand that there is a non-claim ratio, and for similar products elsewhere, the administrative costs are very low. However, there is no such definition drawn in this consultation document. Yes, we do have a submission for Secretary's reference. Well, let's see if we have time for you to supplement later. Next, Mr. Yun Hoi Man from Democratic Party. Thank you, Chairman. Now, about health care reform in Hong Kong, we've discussed the direction for over 20 years. It seems we don't have a direction. Now, the Democratic Party understands that the consultation on VHIS is the outcome of the 2 rounds of consultation of the health protection scheme introduced in 2008. We do have some concerns, as other deputations mentioned, whether this may cause more public hospital doctors to go to the private sector. The administration should conduct a long-term projection on the demand for healthcare manpower so that there is adequate manpower in the public healthcare sector. And also, according to the consultation document, the ratio of using public-private hospital will be 81:19. So theoretically, there should be more resources to provide better services with fewer people using public health care. So the government should deploy more resources to develop primary health care. And we also welcome the standard plan under the VHIS with higher transparency. However, according to reports, the premium under the standard plan will be higher, 9% higher than the existing individual indemnity hospital insurance. And we wonder whether this will cause the standard plan to be less attractive. And the Democratic Party is disappointed in the fact that there is no minimum requirement to meet for group hospital insurance, because very often the insured amount may not be sufficient for those taking out group hospital insurance, and in the end, those covered by group hospital insurance may, because of that, opt for public hospitals instead. And the devil is in the details, because although there may be an extra amount, you must fulfill some requirements. For example, you must be admitted in hospital for a certain number of days first. And we are therefore quite disappointed. Although there is no need for the group hospital insurance to meet the minimum requirements, the government should require that employers or the insurers to provide a voluntary supplementary scheme with adequate level of protection so that employees may be given adequate protection instead of taking out individual hospital insurance on their own. We believe this should be a compulsory requirement on insurers. We also agree to the setting up of a high-risk pool, and on tax, we think that as a financial incentive, tax concession should be offered. Thank you. Next patient, Mr. Chow Ka-ming from Patients' Rights Association. Our association supports the VHIS. Now, in terms of the standard plan, the sum insured may not be sufficient. For example, for non-surgical cancer treatment, for each case, the amount insured is 150,000. So normally, the amount required would exceed the amount insured. So we wonder if this amount could be increased to meet the patient's needs. Secondly, there should be more incentives for the middle class to join the scheme, because for the middle class, most of them already have private insurance policies. So although the government suggests that there could be tax concessions, the amount would be just several $100s. And this may not be sufficient an incentive to attract them to join the scheme. And at present, the expenditure is covered by the public healthcare expenditure, and the government should therefore take the lead by encouraging civil servants to join the scheme so as to alleviate the pressure on the public healthcare sector, and also to lead by example. Also, after implementation of the VHIS in the private sector, the supply may not be able to meet the demand. So the government should provide more support to the private healthcare sector. For example, to allow overseas doctors to practice in Hong Kong and also to build more private hospitals. And also there is a something called a claim ratio. And in the first year, for existing conditions or existing cases, no compensation will be made. For the second year, it would be 20%, and for the third year, 30%. Only after fourth year would you get 100% compensation. For insurance companies in the private sector, currently, in the first year, no compensation will be made, but in the second year, full compensation will be made. So can the government follow this practice? And for high-risk individuals, will all insurers follow the standards of the government? And 3 times or the 3 premium loading capped at 200%, won't it be too much? Next, Mr. Law Siu Hong. Thank you, Chairman, Secretary. I've been in the insurance sector for over 30 years. In the consultation process, just like Chairman, I also consulted many stakeholders, and on the whole, the response has been quite positive. Apart from some details that improvements have been suggested, on the whole, there is general support. And I have a number of points to make. First, on insurance companies, just like MPF, we need a diversity of products, like building insurance for buildings, for cars, for laborers. All these insurance products are actually mandatory, but not in the case of health insurance. So we need more incentive for insurance companies to join. Of course, guaranteed acceptance is one of their concerns, but I think this is what exactly the insured wants. Just like car insurance, well, you can't reject a new driver. As for the premium, say if somebody is age 20 and if he drives a 2000 cc car, then there should be additional loading. So I think this should be left to with the insurance companies to decide, because they have actuaries and they could do the calculations. And we're talking about several 10,000 insurance brokers and agents in Hong Kong, as far as intermediaries are concerned. If we could give them a greater diversity of products, I think they'd be very happy to contact more clients, so that they could use their professional skills to attract more clients. I don't think there will be great resistance in this regard. And transparency and a reasonable premium, along with a diversity of products, I don't think you will encounter great resistance from policyholders. As for intermediaries, on the whole, they support the scheme. Thank you. Thank you. Next, Ms. Chiu Pui from Civic Party, District Development Officer. Thank you. In 2011, the government completed the second round consultation on healthcare reform. It's been 3 years already. This time, on Voluntary Health Insurance Scheme, the government is conducting another consultation. The Civic Party welcomes that. The government is going to introduce the VHIS, and through legislation, insurance companies would be will be asked to join the scheme, so as to divert patients from the public to the private sector, to alleviate the pressure on the public sector. And the standard plan should meet the 12 minimum requirements, except guarantee acceptance and a cap on the premium loading, etc.
There will be a high-risk pool with government injection, There will also be incentives for members of the public to join the scheme. But apart from a minimum requirement on insurance policies, there are no effective regulatory measures for the major private sector service providers. They've launched in the private sector their consultation exercise on reform. It's proposed in the consultation document that the existing regime should be used for regulation. Will there be any regulation on premium? The government cannot say that in terms of administrative fees and commission, a ceiling can be set. Insurance companies cannot increase premium. There can only be a schedule of premium in accordance with age groups. But such a fee schedule need not be approved by the government. Therefore, premium and commission can be increased tremendously, and the government cannot have any control on the industry. At the moment, the expense loading stands at 36%. That means almost 40% are spent on administrative fees, commission, and profits. Only 64% is for medical purposes, and there's no regulation from the government. Members of the public will have to make their own adjustments. So we'll be repeating the mistake of the MPF. That is, administrative costs will stand at a high level. So is this maximizing the use of public money? And the other problem is related to the high-risk pool. Well, you can give us your written comments. Thank you. Mr. Ng Chung Tak. Mr. Chairman, I'm a grassroots. In fact, the proposed scheme is not helpful to us. You say that it targets the middle class. If the middle class can turn to the private sector for services, then more places can be vacated for us to benefit from the public sector. In your consultation document, you quoted a survey. 54% of the public sector users do take out medical insurance. Well, why do they do so? Is it because they want to set their minds at ease, or because medical insurance is useful to them? And the other question is, why is it that with medical insurance, they still use public sector services? In fact, there are not that many such people. If you take them out, after implementing voluntary health insurance, can you guarantee that these 54% will disappear from the public sector? In fact, government investment in medical and health services in the public sector is very few when compared with American, European countries and Japan. Very few investment, or a very low level of investment. I don't oppose regulation of the public and private sectors in terms of medical services. But then you need to step up regulation. Now you want people to go to the private sector. But in the private sector, do they have sufficient capacity to serve their targets, which include not just Hong Kong people, but foreigners? I think they can barely cope at the moment. So in future, if the private sector cannot cope, people will go back to the public sector. So the picture is, you want people to go to the private sector, but when the private sector has a great deal of demands, do we have enough doctors? In Hong Kong, we're always short of doctors. So that will add to the burden of the public sector. So when the government launches medical and health care protection or voluntary health insurance, etc., etc., the government should consider increasing resources for the public sector. Don't think that with this major reform, people will go to the private sector and the public sector will be okay. Let me tell you, in Hong Kong, every person is entitled to treatment. Well, Dr. Lee, please be seated. I'll let Professor Leung speak first. Next, Professor Raymond Liang, Emeritus Professor of the University of Hong Kong. Mr. Chairman, in Hong Kong, we adopt a dual-track approach. The public sector is the mainstream, taking care of the vast majority of the public. And in Hong Kong, we have the hospital authority offering high standard service in the public sector. That's very important. That's Hong Kong people's safety net. No matter what reform we have, we must maintain this safety net with the support of the Hong Kong government. Now, what about this voluntary health insurance scheme? Is it really necessary? For middle-class citizens, they do need such a scheme. Why is it that they want to take out insurance? In fact, they're not dissatisfied with the HA's service, but they're still not satisfied. For example, in terms of ward environment, many middle-class people want more privacy, and they may even want to choose their own doctors, which is not allowed under the HA. And some drugs are more expensive, and they have to pay even under HA. And sometimes the waiting time is too long. Well, there will be waiting time in the public sector. That's the case throughout the whole world. It's just a matter of long or short waiting time. So the public sector cannot resolve this waiting problem. We have the four major pillars or objectives under the HA: emergency service, grassroots service, expensive services, and training of medical and healthcare personnel. These 4 points are priorities. For the non-emergency services, people will have to wait. So if we can have private medical insurance, people will have a choice. You can opt out of the public sector. Do we need a government-arranged voluntary health insurance scheme? Is the present system inadequate? Are there difficulties? If you consult people who take out medical insurance, you see that they're really aggrieved. As a doctor, I also had to fill up a lot of documents for my patients. I think, Mr. Chairman, you also have that experience. Now, we don't have a minimum standard set for the private sector. Well, in certain cases, they are really very bad. It's just tantamount to not taking insurance at all. And sometimes in their policies, they write terms in very small letters. So we really have to maintain a high-quality insurance regime. Thank you. Next, Dr. Pierre Chen, President of the Hong Kong Public Doctors Association. Good morning, Mr. Chairman. Dr. Ko, members, I'm Pierre Chen, President of the Hong Kong Public Doctors Association. I welcome this voluntary health insurance scheme. In the past month, I tried to collect opinion from doctors by emails, electronic means, or talking to them directly. By and large, my members welcome the scheme. I'd like to continue to have their views. As for the waiting time at specialist outpatient clinics, you know that sometimes you have to wait for 2 years before you can first see a doctor. That is true, and that's not ideal. Different colleagues have been working very hard at the peak of the flu period. Our colleagues have to shoulder a workload that is 2 times or 3 times the normal workload, so they have to work quicker. And for the hospital authority, we're talking about $40-odd billion per year. All right, money is spent, people work continuously, but still the effect is not ideal. Not ideal for the public, not ideal for our colleagues. So this is rather strange. Money and effort have been spent. For myself, I'm also waiting for medical reform. I've been waiting for many years. Doctors and the public have been waiting for a long time. All along, the government is saying that it will take care of the poor, the elderly, and the weak first. Just now, the professor mentioned the 4 major pillars. Those will not change. The government will be the underwriter, so to speak. So this voluntary scheme will only allow some non-emergency patients who can afford the private sector service to acquire the service. Well, there are a few important points. First of all, the right of the patient to choose. Well, if the patient chooses to wait, you have to let him wait even for 2 years. Number 2, if he has taken out insurance, if the government has assisted him to take out an appropriate insurance scheme at an affordable level, the patient can opt for the private sector, say for a minor surgery or a physical examination. Now that option is important for the patient. Well, if this can reduce waiting time in the public sector, is already a win-win situation. So please support the scheme. Dr. Lee, are you ready? All right, then next, Hong Kong Private Hospitals Association, Dr. Anthony Lee, their chairman. Given my experience in my practice, I very much support this voluntary health insurance scheme. Why? In actual fact, at the moment, many patients who receive services in private hospitals and also have medical insurance, the protection is not enough. First of all, if you are older than 65 years old, you cannot take out any insurance. And then pre-existing conditions will not be covered. As for claims and compensation, just recently, the University of Hong Kong came up with some statistics for discharged patients from private hospitals. Say if hospital fee is 100, very often the patient has to pay 40%. That is, out of pocket, the patient has to pay quite a lot. For our group of hospitals, the compensation rate is around 60 to 70%, and the patient has to pay 30 to 40%. Under this voluntary health insurance scheme, a minimum will be set. So that sounds good. But will this be sustainable? The calculation of $3,800 should be able to sustain the scheme. For sure, in future, in the market, there will be market forces to stop ready increases in premium. When they calculate the premium, they consider the claim ratio of 60%. This is just like group insurance. The government is to put in a great deal of resources for promoting this voluntary health insurance scheme. So I think you'll be able to bring that down to 80%. In other words, there's still a great deal of room for maneuvering. Well, we're not passing responsibilities and businesses to the private sector because there'll be a regulatory regime. There'll be quality assurance, and for new beds, packages have to be offered, and a certain percentage of cases have to be put under the basic rates. Well, why is there resistance from the private doctors? It's because they always want to maintain status quo, and they are worried that the claim ratio may be increased by the government to 80%.
Yeah.
Next, the Society of Hospital Pharmacists of Hong Kong, Mr. William Choi. Thank you, Chairman. The Society of Hospital Pharmacists of Hong Kong supports the government's introduction of the Voluntary Health Insurance Scheme. We believe that by implementing the scheme, we can strike a balance between the private and public healthcare sector so that patients can get protection as far as hospitalization is concerned. We believe that the insurance products should meet the minimum requirements set out. Even for group hospital insurance, they should meet the minimum requirements. Although the government says that they need incentive to attract employers to join the scheme, but we believe there are other ways to attract employers to buy group insurance for employees. And we also support the conversion option. We also support the setting up of a high-risk pool. The government, in the long run, should consider extending the coverage to individuals' outpatient clinic, in particular, specialist outpatient clinics, because younger members of the public, whom we call middle class or the middle-aged, use specialist outpatient clinics, and this can help the financial viability and long-term sustainability of the scheme. And tax concessions are also welcomed by the society. Policyholders of individual indemnity hospital insurance on the expiry of the terms can choose to convert the policy to one under the VHIS. We also support the setting up of a regulatory body under Food and Health Bureau to monitor the implementation of Voluntary Health Insurance Scheme, and also to set up claims dispute resolution mechanism. This can provide an alternative to public healthcare services, that is private healthcare. We welcome the stepping up of regulation over clinics and centers providing high-risk ambulatory procedure or day procedure, so as to attract more to use the service. Finally, we believe that there should be a mechanism to prevent the abuse of health insurance by the public and service providers. If you want the system to be sustainable, there should be a mechanism against claims abuse. Thank you. Next, Ms. Elaine Chan, Deputy Chair of Task Force on Healthcare Reform of the Hong Kong Federation of Insurers. Thank you, Chairman. Secretary, good morning. We're talking about 12 minimum requirements in the VHIS. Well, many have spoken on that. Guaranteed acceptance, coverage till 100 years old, and covering outpatient clinic and ambulatory procedures. All these are good, but let's not forget that we're talking about 650 minimum protection, meaning 650 for hospital admission charges and other miscellaneous hospital charges, so on and so forth. That means all 12 minimum requirements must be met before we sell the top-up products. Well, having been in the insurance sector for so many years, we understand that there are different products for the needs of different customers. According to the Federation's statistics, for a premium of 3,000 plus, well, 3,600, more than half of our policyholders pay a premium of less than 3,600. Why is there? Why are there customers paying a premium of 3,060? Perhaps one group may have coverage by the company's group hospital insurance, and they'd like to have extra protection by taking out individual indemnity hospital insurance. And the second group may be those who have taken out the policy at a young age, and as they earn more, they would like more protection. And the third group may be young people. Young people, as they graduate and join the workforce, may like to take out insurance policies, but they're unable to afford huge premium. That's why more than 50% of policyholders now pay a premium of less than 3,600. So I'll just call this an admission fee, or the lowest threshold, meaning that some customers won't be able to take out any policy at all if the premium is too expensive. We don't see adequate choices for customers, and the products are not diverse enough to meet the needs of different customers. And currently there are 1.9 million in Hong Kong who have taken out reimbursement-based insurance. And within the first year, if we are to invite them to convert to the VHIS, we must pay attention to this point. I don't know how many of you here have insurance policies. Now say I now invite you to convert to the VHIS because of guarantee acceptance and coverage to 100 years old, and also tax concessions, well, only for the 5 to 8% in Hong Kong. And this will affect the 1.9 million customers in our industry. Next, Mr. Terry Zhang from the Medical Insurance Association of the Hong Kong Federation of Insurers. I'm chairman of the Medical Insurance Association of the Hong Kong Federation of Insurers. Well, let me share with you some figures. Every year, that when we conduct statistics every year, 88% of claims are from private hospitals or private clinics. Only 12% of patients had the procedures done in public hospitals. So what protection can we give to our policyholders? Out of $100 medical expenses, $80 are given to the insured, which means there is a $20 out-of-pocket payment. In terms of risk management, this level is reasonable, so that there is cost sharing between the service provider and customers, so as to prevent moral hazard or the hazard of abuse. And the association also supports the healthcare reform of the government, so as to strike a balance in public and private healthcare sectors development. However, we believe that as far as the consultation of the VHIS is concerned, there are still technical problems and details to be ironed out, and it is questionable whether the scheme can run for in the long run. First, on the premium of 3,600, when the 12 minimum requirements are to be met, according to the projection made in 2012, the premium, or the basic premium, should be $3,300. And because of the 12 minimum requirements, the figure could rise by 45%. And there is also a age band premium, which means the basic premium is only for those aged 40 or below. So when we talk about $3,600 being just accounting just for 9%, this is misleading the public. And on increase in medical costs, well, nothing has been mentioned. In 2010, we discussed with the government, and in that report, there was a suggestion to implement this by way of a DRG, so as to enhance transparency and also to enhance efficiency and to prevent spiraling of premium. However, in this consultation document, or in this proposal, the suggestion of using DRG is not included. So in terms of medical inflation in the future, without striking a balance between demand and supply, the premium may go up. Next, Mr. Mike Lee, Member of General Committee of the Insurance Claims Complaints Bureau. Thank you, Chairman. I represent the Insurance Claims Complaints Bureau. We believe that after implementation of the VHIS, all complaints related to the scheme should come under the Insurance Claims Complaints Bureau. First of all, the Bureau has been set up for 25 years. Over the past, we have been providing a free service to members of the public. Adopting a low-cost and high-efficiency approach, we resolve disputes between policyholders and insurance companies and prevent lengthy legal procedures. And complaints are dealt with by members of the Insurance Claims Complaints Bureau with a neutral stance, and the members must possess financial knowledge, and the chairmanship must be approved by the FSTB first. And as for two other members, they come from the Hong Kong CPA, so there is no questioning and the Consumer Council. So there is no question on the neutrality of the Bureau. And if the complainant is not happy with the result of the adjudication by the Bureau, he will not be deprived of the chance to pursue it legally. And we have annual press releases on the number of cases adjudicated, the number of complaints, etc. We have high transparency, and we help the public understand the protection of their insurance policies better. Thirdly, we handle different sorts of insurance claims, not just medical insurance claims, but over half of the claims have to do with medical insurance, and on average it takes 3 months in processing these complaints, and therefore there is experience in handling these medical claims. And in the process of mediation, interpretation of terms and clauses in the policies may be involved. Now, the VHIS proposes the use of mediation and arbitration, and the mechanism is similar to the Financial Dispute Resolution Center. The fees may be lower than the cost of litigation. Still, time and money will have to be spent. And I want to point out that most of the claims involve just a very small amount, and the claims dispute resolution mechanism may not be convenient for the public, and we therefore suggest using the Insurance Claims Complaints Bureau service instead. Next, Mr. Kwok Chanhua from the Federation of Hong Kong Industries. Well, the FHKI supports consolidation of the public and private healthcare sectors, and we therefore support the government's VHIS because this will encourage members of the public with means to receive operations in the private healthcare sectors and private hospitals and alleviate the burden of public healthcare system. And there are a number of benefits under the scheme. There will be guaranteed renewal, guaranteed acceptance, and there is no lifetime benefit limit. And all these can address the shortcomings of the current policies that we have. And this doesn't cover group hospital insurance.
Because employers should resort to their own means to retain employees. So they should work out their own insurance schemes. At the same time, we can offer another option to the SMEs. They can opt for the minimum standard under the VHIS and offer corporate insurance to the employees. We're also in support of the high-risk pool, the HRP, which is to protect the high-risk people. But of course, there's room for improvement for the VHIS. The moment we don't have enough outpatient services. So the government should look at this mismatch in terms of medical policies. And we should study whether or not we have enough beds and personnel so as to address the extra workload in future. So there should be more hospital beds as well as more training for the personnel. And tax concessions can be increased so as to attract more middle-class people to join the VHIS to ease the workload on the public sector. So you should adopt a comprehensive approach. There should be additional medical financing and professional support. And you have to give more support to the hospital authority comprehensively. Next, Mr. Jeffrey Pong from the Liberal Party Youth Committee. Good morning, I'm Jeffrey Pong. The concept of standard scheme under the VHIS carries 12 requirements, as well as other measures like tax rebate. So as to provide more choices to the public, and this is a voluntary scheme. On the whole, the Liberal Party supports the scheme because there's no additional work burden on the business sector. A number of requirements provided under the VHIS can target and address the inadequacies of private insurance policies, and certain disputes can be resolved, for example, in terms of pre-existing conditions. As for consent documents, as well as no-gap packages, they are good because the consumers will be more informed. As regards doctors' fees, we hope that insurance companies joining the VHIS can disclose clearly the compensation ceiling in each case so that the patients will have certainty. We want that to happen. At the end of January, the Liberal Party conducted a questionnaire survey on public understanding and acceptance of the VHIS. We interviewed 1,000 citizens. On the average, their income is $10,000 to $12,000 or even below $10,000, aging 40 to 65 in the main. 78% of the 1,000 interviewees did not understand the VHIS and its content. When we asked them whether or not they'll join this VHIS, over 40% of the interviewees answered in the affirmative. That is, they would join. We asked why they would join or not join. They said that the main reasons, or 37%, said that this VHIS is better than the existing private insurance schemes. And some said that they now have difficulties in taking out medical insurance. And there are other respondents who opined that the private sector services are sufficient. So we would like more people to be able to join the scheme. Next, Dr. Louis Shi, President of the Hong Kong Medical Association. Thank you, Chairman. Dr. Ko and members, like other members of the public, the Hong Kong Medical Association went through the 12 requirements. Not many people will support those 12 requirements. As I mentioned to Dr. Ko, for fees and charges, our association is fully in support of enhanced transparency. Before admittance to hospitals, the patient concerned should know the fees and charges such that he or she can have a choice. Otherwise, when medical fees and charges as well as private doctors are covered by this network under the VHIS, then a business corporation, so to speak, may be formed. So we would not like to see escalating fees and charges. Well, all costs will be passed on to the consumers. If you ask the insurance industry to cover the old age patients, patients with long-term illness or serious illness, the insurance companies will try to attract more people with no illnesses to join the scheme. Well, if a person is contributing through the scheme throughout his work life, at the age of 60, when he retires, he can no longer afford the premium, so he'll go back to the hospital authority. That means young persons are subsidizing the elderly and the chronically ill. May I digress a little bit here? For the provision of medical services at the moment is a problem in Hong Kong. A few weeks ago, the Chinese university organized a seminar in the CGO with foreign experts participating. They find our system strange. How to control chronic illnesses, how to reduce the number of patients to be admitted to hospitals, etc. The patients are to bear the cost. They find this strange. So we must have preventive medical services. Take, for example, you can have vaccination to reduce the number of flu patients being admitted to hospital. I think we all understand this. Next, Dr. Eugene Chen from the Association of Hong Kong Professionals. Thank you, Chairman and members. First of all, I have to say that our association supports this VHIS. In the past 10 odd years, we had a number of consultation exercises without arriving at any conclusion. There's still imbalance, and fees and charges in the private sector are ever rising. And lack of services or inadequate services in the public sector has deteriorated. So we must try to do something to maintain our efficiency. Streaming can shift certain patients to the private sector, thus easing the pressure on the public sector. But many people still have reservation over the VHIS, so maybe the government should explain more on the following aspects. Number one, balance between the public and the insurance sector. The service target is the public. So the government must have appropriate regulation of the insurance industry such that while having a reasonable profit, the insurance companies can serve the public. And minimum requirements should be set. Very often members of the public have misunderstanding about the terms of insurance policies. So you have to address the worries and opinion of the insurance sector. Number two, balance between the public and the public sector. At the moment, more and more people are turning to the public sector. The government is to inject funds into the VHIS, but that won't be endless. So members of the public have to plan for themselves. That is to take out insurance with subsidy from the government. Anyway, at the end of the day, the public and the insurance companies together will bear the responsibility. Number 3, balance between fees and charges and patients going to private hospitals. Well, members of the public are by and large satisfied with private sector services. It's just that they feel the fees and charges are a bit high. So the government should discuss with insurance companies such that they can provide appropriate services to the patients at a reasonable level of profit. Otherwise, the private sector will become ineffective. This VHIS will offer a certain degree of protection to the public, where some members of the public may not want to subsidize others, but different insurance schemes are to offer protection. So the VHIS must attain 2 targets. First of all, it should be affordable to those who want it. And secondly, we should have a high-risk pool. Besides, we should shorten the waiting time and reshuffle the resources. Next, Provisional Hong Kong Academy of Nursing Limited, Ms. Civic Leung, their Vice President. Good morning, Chairman and members. We would like to put forth 5 points today. First of all, our Academy supports voluntary health insurance. For those who can afford it and those who can afford fees and charges in the private sector can benefit from this scheme and also ease the burden on the public sector. Now, we would like to know how the scheme can be sustainable. Thirdly, this scheme is about medical and health care and hospitalization. But what about care needed by patients during the rehabilitation period? Household care and physiotherapy services, for example. So all these should be addressed such that the public sector can be more efficient. Fourthly, in the beginning year, all people will be accepted. Starting from the second year, only people below 40 years old. Why is it that people above the age of 40 will only be covered in the first year? How can the government ensure that people above 40 learn of the information in the first year? And what about planning for personnel? In 2012-13, we got 100 more places in the medical schools. Also, an increase in nursing quotas. Our academy is of the view that an additional 40 nurses won't be able to address the enhanced demand and aging population. So more undertaking should be given to the nurses. Next, the Chinese General Chamber of Commerce, Mr. Anthony Kwan. Good morning, Mr. Chairman and Dr. Goh. In principle, we support the VHIS, but we have a lot of worries about the details. One of the major problems was brought up with Dr. Goh last week. Now, when you take out medical insurance at the moment, not all diseases are covered. For the private hospitals, they only cover 40-odd% of the diseases, and 50-odd% would be referred back to the public hospitals. After the implementation of the VHIS, how can you ensure that this trend can be changed if 50-odd% of the diseases still go back to the public sector? Then what is the meaning of having this VHIS? And then zero regulation is another problem to address. After the launching of the VHIS, how can you ensure that the government can mandatorily require private hospitals to take on more patients?
I understand that for the voluntary health insurance scheme, you're going to impose some mandatory requirements on hospitals as well as insurance companies. And there won't be many problems with insurance companies. But in terms of medical facilities, hospital beds, manpower in the private hospitals, if you don't have anything to help the private healthcare sector, then they'll be short of supply, and ultimately the patients will go back to the public hospitals. And on tax concessions may not just apply to the payment of premium. It may not be confined to a certain limit. For example, if you pay a premium of a certain amount, you get a proportionate concession. So for the VHIS, it really has to do with the restructuring of our public healthcare system. In fact, other deputations have spoken on the issues. I don't think there is much divergence in our views. I think Secretary will understand what the problem is. The problem is with private hospitals. If you can't deal with that, this is pointless, no matter how detailed your scheme is. Next, Mr. Victor Apps, General Counsel, Member of Employer Federations of Hong Kong.
I was 40 years in the insurance industry, and I was also on the working group for the HPS. The Employers Federation agrees with the basic idea of VHIS. We like the standard plan with the 12 minimum requirements are fine, but we think there are a lot of problems in the report in terms of how it will be implemented in the data. If you look at the existing market, we need to know much more about who currently buys individual hospital indemnity insurance. The report fails to give us much understanding of the current system. The data is extremely difficult to understand. We are told that 25% of Hong Kongers have hospital insurance, and also told that 54% of these people still choose the public sector. Why then did they buy it? Perhaps the data confuses the true indemnity products with the hospital cash products, which are very popular in the insurance industry. I don't know what the problem is. But also the very high expense loadings of 36 and sometimes I saw 40% expense loadings in these products would be totally outrageous for an indemnity insurance product. So if the insurance industry truly is selling indemnity insurance with a 36% loading, that's a disgrace, and because it should be more like 20% or something like that. Finally, and particularly important, I think, in this discussion, is that virtually nobody over the age of 65 has individual hospital insurance in Hong Kong. Virtually nobody. And a lot of the people in the hospitals are over 65. And so that group is being... And it's almost funny in the report, somebody asked a question about the elderly. And so they give an example of somebody of age 50 and say the premium for that person will be $15,000 a year. That's not the elderly. The elderly are 70. How much should they pay? It'd be a hell of a lot, a very big number. So who would buy the VHIS as defined now? There's nothing in the report that talks about that, which groups of people, which age groups would buy the product, because that's absolutely crucial if you're developing a new area. This is clearly not a product for poor people. It's going to be much too expensive. As defined, the VHIS will be attractive to the relatively rich elderly and to those with no medical problems, because both of those groups, at the moment, the elderly and ones who cannot buy individual insurance at the moment. So of course they'll buy it, and what's clearly will happen is that will be the major class. And I'd love to see some analysis of the report that looks at that. The premiums it talks about, I think it come from thin air. They've talked about the $3,300 premium now, but that apparently is for a product that 54% of people don't bother to use. So that's going up to $3,600 for a product that will be used. It's good. clearly, this will move the individual insurance market into much elder age groups, because this is where the need is. That data should be in the report. It should be studied. Talking about these averages of 3,600 is meaningless, because the numbers it's going to skew dramatically. So, in my opinion, the report is good in its concepts, but the data is extremely suspect and needs to be improved substantially before anybody approves it. Thank you.
OK，唔該晒。
Thank you. Finally, New People's Party. Mr. Ng. Thank you, Chairman. With aging population and inspiring medical costs in Hong Kong, there is a challenge on the sustainable development of the healthcare system. However, we should not just stream patients from the public to private sector. Rather, we should reform the hospital authority. It has long been criticized. Well, in 2013, in August, a review committee was set up to review the overall operation of hospital authority. However, we have yet to see any work done by this review committee. Before ensuring the optimization of the use of resources in the public healthcare sector, the government introduces this voluntary health insurance scheme for the middle class and for employees who do not pay the standard tax rate. The tax concessions are just too insignificant. Also, insurance companies and private doctors stand to benefit if public resources are used to subsidize the VHIS, not the public, not the patients, because the tax concessions are insignificant. As for the standard premium, it is suggested that it should be set at $3,600 per year, which has totally ignored the fact of medical inflation. It is said that premium would increase by 5 or 6% per year because of medical inflation. And by the time it's introduced in 2016-17, the premium should go up to about $6,400 to $4,600 to $4,800. The premium is on the high side, and there is no incentive for ordinary members of the public to buy, to take out the insurance. And there is no incentive to encourage young people to join the scheme to reduce reliance on public healthcare system. And it's said that $40 billion would be earmarked for a high-risk pool, and for the public-private partnership scheme, it has not been well supported by the public or the healthcare profession. With more resources deployed, the scheme will be perceived as a waste of public resources. There is no clear justification for introducing VHIS. The IIA set up will most likely be a duplication of the OCI, Office of the Commissioner of Insurance, and this will also give an impression that you're benefiting your own industry. All right, the deputations have spoken. I'll ask Secretary to give a brief response. Chairman, how much time will I have? Sorry, I really have to ask because you want me to give a brief reply, so I need to know how much time I'll have. Well, actually, there is no time limit. All right, then I'll begin. Or would you like me to take members' questions as well? Well, I'm afraid you may not be able to remember everything, so maybe you should respond to deputations first. I won't give you any time limit. Thank you, Chairman. Thank you, representatives of different political parties, professional bodies, and associations from different sectors. I know from your speeches that on the whole you support the VHIS, the majority of you. Of course, I can't say all of you. And and yet some concerns are raised, and let me respond to these points. First, I agree very much with you that whilst you support the scheme, the dual-track system of public and private healthcare is being subject to a huge challenge with demographic changes and technological developments. There is also at present huge pressure on the public healthcare sector. So, from your speeches, I understand that you support, you think there should be continuous support for our public healthcare system, and I agree with that. And apart from that, we should place more emphasis on primary and preventive healthcare, and I agree with that as well. And I'm happy to hear that you quite understand our concept. That is, where the purpose of the VHIS is to encourage those in the middle, those with means and those who'd like to take out insurance to be covered by insurance in future, and also to be free from any problems with policy renewal in future. Thirdly, there may be people who have taken out insurance policies and are not using them. We hope in future that they could make use of their policies. And for conditions not covered, we hope in future that they'll be covered. Of course, this cannot replace our work in promoting primary health care. But still, we can reduce the reliance on public hospitals. Now, on implementation details, there are 12 minimum requirements, and I note the general support for them. For the high-risk pool mechanism, I note that you have really done a lot in getting a better understanding of that. So let me respond to some concerns. First of all, quite a lot of you think that we need more publicity, and may I respond by saying that we will do more in terms of publicity. We already have APIs on TVs, and with the launch of the VHIS, we'll of course step up publicity. Secondly, some deputations are concerned about the premium or increase in premium under VHIS. According to the consultant's estimation, it will go up by 9%, but some opine that it will go up by as much as 40%. From different angles, may I explain that premium will not increase by such a huge extent, because if the VHIS is successfully implemented, the number of people taking out insurance policies will increase, and in terms of risk sharing, the efficiency will be enhanced, and this will help push down or stop increase in premium. And also, the VHIS seeks to address the problem existing in the current market, that is a lack of transparency. In future, with the standard plan and with standardization of policy forms and terminology, members of the public will be able to compare different insurance policies in the market, so that competition can be introduced and there will be pressure against spiraling of premium. Thirdly, as pointed out by many, even after taking out the VHIS, not everyone will go to a public hospital. Of course, there is, according to a survey, even for those who have taken out individual hospital insurance products, 54% of them still in the end choose a public hospital over a private one. But this is not necessarily the case. And this may not happen every time. What I think is that, ideally speaking, we should be able to increase the chance of policy holders really making use of their insurance policies.
Because many patients actually ask the private practitioner to refer them back to the public sector. Anyway, under the VHIS, we would like the patients to use private hospitals, but not to the extent of 100%. And we need not set 100% as our target. Hong Kong is different from other jurisdictions. In many other jurisdictions, if you don't have medical insurance, you can't be hospitalized. And the reality is that even with medical insurance, patients elsewhere may not be admitted to hospital. So in Hong Kong, we're trying to provide another option, a real option, a genuine option to the public. If at a particular juncture you want to go to a private hospital, you can do so. And on other occasions, you can still opt for public hospitals. For example, for the very serious diseases, patients covered by medical insurance may still want to go back to the public sector because we have cross-disciplinary medical teams. Anyway, under the VHIS, we would like to have more patients going to the private sector. And in other jurisdictions, patients may not make full use of their medical insurance. Therefore, the pressure of increased premium in future shouldn't be under huge pressure because of this safety net in the public sector. So I think even if premium is to rise after the implementation of the VHIS, the rise will only be moderate. And then there's this observation about young people. To a certain extent, that observation is correct. But this VHIS is not for fresh graduates because the tax rate for them is lower. Through VHIS, we'll do a great deal of publicity. We'll let our young people know that the earlier they take out insurance, the higher the protection will be for them. Some young people may now feel that they will not need to use the VHIS in 10 odd years' time. Well, when they are in their 50s or 60s, their health may deteriorate, and they may not be able to get a renewal for their medical insurance. But under the VHIS, they can take out health insurance at an early age, and then they can be guaranteed lifelong renewal without additional premium. So that will be an incentive for our young people to take out health insurance, and that will be very helpful in sharing out burdens. Now, there are two major worries. First of all, about the insufficient capacity in the public sector. Here I can inform members that we already have plans to develop private hospitals as well as expand existing hospitals. By the year 2020, the capacity of our private hospitals should have been increased by 40%. So if you worry that private hospitals will be saturated, thus causing fees and charges to increase, I'm of the view that if private hospitals can cope with the workload, by the time VHIS is implemented, the private hospitals will have already been equipped to cope. As regards regulation, we propose to have consultation because at the moment, our laws do not support enhanced regulation. So, in future, we would like to be empowered by statutory provisions to enhance our regulation of insurance premium. As for the high-risk pool, some friends are worried about the saturation of high-risk pools. But the high-risk pool is to offer a reasonable time frame for the public for deliberation. If 1 year is not enough, we're willing to consider a longer time frame. No matter what, we think we should set a reasonable time limit. Why? We should be fair to the public. If after a period of time you still not opt for health insurance, the service has to be made available to other members of the public. So after the deadline, the service will only be available to those below 40. Now, by setting this threshold, we're sending a strong message to our young people. If you think that you are very strong now, you don't have to take out health insurance, you believe you continue to be healthy, we'll tell you that we're not going to wait till a healthy person to become a high-risk person in 20 years' time. We're not forcing young people to take out this insurance, but we have to ask them to face this question. In future, if they use public hospitals, no problem. But if they want to have one more option in future, then they should consider this health insurance. The high-risk pool won't expand indefinitely. We'll have an injection of a few $billion, may not be $4.3 billion, but a little bit more, still billions only. We don't rule out future injection of a small sum of money, but this high-risk pool won't be too huge. And then there's this remark about the reserved funding of $50 billion. How will that be used? Now, the Financial Secretary mentioned that not just because of VHIS, is for overall medical reform. So apart from the few $billion for the high-risk pool, tax rebate in future will cause the administration to lose some tax proceeds or revenue. That will not be covered by the $50 billion. But you know that some invisible expenses are actually done under tax concessions. And then part of this $50 billion is to promote collaboration between the public hospitals and private hospitals. Apart from this voluntary scheme, there will be another proposal to ease the pressure on the public hospitals and to ensure balance between the public and private sectors. That means some patients will be subsidized such that they can go from public hospitals to private hospitals. I don't rule out the possibility that eventually we may get some surplus from the $50 billion that will go back to the public coffers. Now, we have to be responsible for the facilities in the public hospitals. Well, part of the fund will go back to the public coffers. But on the other hand, we're asking for a lot more from the Financial Secretary. You'll be able to see that in the upcoming budget. Well, I don't think I can answer all questions raised just now, but I'd like to say something about regulation. Under the Food and Health Bureau, we suggest the establishment of an insurance regulation division to ensure that a minimum requirement is satisfied under the VHIS. But there's another function, that is how to investigate into claim disputes. We keep an open mind at the moment. I note that some of the friends here were of the view that there should be a separate complaint mechanism. So we'll take public views first before making a final decision. Final point. Some grassroots consider them not benefiting from VHIS. So I'd like to say something to the grassroots public. Yes, this VHIS is not for the grassroots. We hope that middle-class residents who can afford health insurance can take out health insurance and be able to use it. For the grassroots, there must be measures to help them to attain this balance between the public and private sectors. Now, there is this concern that if everybody opts for the public sector, then for the grassroots, they have no option, they have no choice, so they'll have to wait for a long time and they'll face an even worse situation. So we'll honor our responsibilities in the public sector. At the same time, we'd like to have something to ease the pressure on the public sector such that grassroots public won't have to wait too long. Well, we should have sufficient time for a discussion. Well, those who would like to discuss with the Bureau Director, please raise your hands. Let members ask first, and then I can let the deputation supplement. The clerk will jot down your numbers. All right, the floor is now open to members. Yes, we have sufficient time, but perhaps for the first round, I should accord 3 minutes to each member. Well, usually you exceed 3 minutes. Oh, I respect your opinion. 5 minutes then. Mr. Wong Kok Heng. Thank you, Chairman. I'd like to thank the deputations and individuals who have come today to offer their invaluable advice on VHIS. I'd like to say something about tax refund. Now, Dr. Ko, Secretary, if you want to attract more members of the public to join, then you have to give them a bigger carrot. If you don't have a bigger carrot, you won't be able to encourage members of the public to take out health insurance. Well, just now you said that this VHIS is not for the grassroots, but for the middle class. In fact, you need not say so. If you can attract more people to use private hospitals, then it will be helpful to the general public because the pressure on the public sector will be eased. In fact, in the public sector, we do not have enough services. So if more members of the public opt for VHIS, they'll be helping the government, the society, and the public. They're actually helping the public hospitals as well in terms of easing of workload. So the government should reward those who opt for VHIS. So is this ceiling of $3,600 too meager? So, Dr. Koh, how did you do your calculation to arrive at $3,600? Why not $3,700 or even $7,300? And the best solution is not to have a cap. So you look at the size of the insurance taken out before you determine the reward. I'd like to have a response from the government. I'm more greedy in this regard.
So if somebody takes out insurance voluntarily, you should increase the amount of tax concessions so as to really help them, because the middle class often criticizes the government for not providing any support for the class. So can you give them full tax concessions? I thank Mr. Wong for his question. I agree with you that there is no need to distinguish between the grassroots and middle class, but I just want to respond to the point raised by some, and the saying is indeed correct. I cannot really dispute the fact, because those who will be joining the VHIS will be coming from the middle class, the majority of them at least, and we also understand that there is great need and great reliance on the public healthcare system by the grassroots. I'm not really trying to distinguish the two or separate the two groups, but we all need to understand that the scheme will be beneficial for the whole of Hong Kong. As for the extent of tax concessions, whether more concessions will be provided, I wish to point out that in the consultation document, we only give one example. When the VHIS is formally, before the VHIS is formally introduced, we can't give you the exact figure. That's why we only use an example. And when the VHIS is formally launched, the Financial Secretary will, based on the circumstances at the time, set the tax concession rate at the suitable level. Whether we can scrap the ceiling, as Mr. Wong suggests, I don't think so. There should be a ceiling for tax concessions, because for private hospitals, as you know, we do have a diversity and a range of private hospitals. Even in one private hospital, we could have a general ward with 6 to 8 hospital beds, or wards with just 2 to 3 beds. So there are different standards. If you say we should not impose a ceiling, we may then be subsidizing people to use first-class wards instead. And of course, the public is mindful of how we use public money. So when we talk about the VHIS, we're talking about general ward in private hospitals. There must be a ceiling. But definitely there will be tax concessions pegged at a suitable level. One more word, Chairman. I hope Secretary could reflect to Financial Secretary that the government should consider the attractiveness of the scheme. Because if it is attractive enough for more to join the VHIS, then everyone will stand to benefit. Of course, for those living in or residing in a first-class ward, whether tax concessions should be offered as well, we can consider that in greater detail. But anyway, there will be a reduction in public expenditure if more concessions can be offered. Yes, I agree that there should be sufficient incentives. Your sentence is really long. Mr. Chan Kim Po. Well, first of all, I thank deputations for attending. I'd like to clarify some figures. Just now, I think the public would be very confused if the political parties and the medical sector are quoting wrong figures. So I want to clarify these figures. Some mentions the expense loading being 40%, but in fact, according to the document, in 2013, the figure has dropped to 31%, so it is at most around 30%. And in fact, administrative costs accounts for only 25%, whereas claims accounts for 75%. So don't quote 40% again. It should be 30%, not 40%. And Dr. Lee, who has now left, said that it should be some 20%. But don't don't mislead the public by suggesting that the level is 40%. It is not. Well, out of the 20-odd%, some 10% goes to intermediaries. And Mr. Law Su Hong, who is here today, could say something about the functions of intermediaries. He is advisor and chairman to a number of associations for intermediaries. I'd like to respond to Secretary's remarks that the insurance industry is very concerned. Over the past few years, we have been sending our representatives to discuss with the administration and with the Food and Health Bureau, and we are disappointed in the government for not implementing the measures like the DRG. Even Singapore is doing that. Well, there are 12 minimum requirements in the end. Maybe Ms. Chan could say more on the concerns of the insurance industry. Now, perhaps she can just raise 2 or 3 points. For standard plan and 12 minimum requirements, well, we don't have any problem with these because this will enhance the public's recognition of our industry. But the point is, this will make the scheme unsustainable. Some policyholders may be very willing to take out the policy under VHIS at first, but if the VHIS is not sustainable, then things will be problematic. I'd like to respond to Secretary that a number of points. First of all, because of more policyholders, there will be a cost-sharing effect. But what we're concerned is the lack of attractiveness. For the $50 billion earmarked originally, it said that no claim bonus could be provided to policyholders. If all the newcomers are high-risk groups, or belong to the high-risk group, then there is no chance of increasing risk sharing or cost sharing, because with this system of subsidizing high-risk people, this will not really benefit the insurance sector. For newcomers, they may be all belonging to the high-risk group. So we really need to attract more healthy and young people and encourage them to take out insurance in the long run so as to really benefit all. Secondly, you are wrong in saying that with greater transparency there will be competition and this will cause a premium to be reduced or the increase in premium to be milder. But we all know that the problem lies with hospital beds in private hospitals because a great portion of the premium goes to private doctors. So no matter how you criticize the insurance industry, well, the expense loading, like I said just now, is just 25%. But there is no one to control expenditure on the other hand. So I agree with Secretary that your starting point may be good, but your policy may actually cause the whole scheme to be harmful despite your good intention. We're going to have another public hearing soon, but please explain to the deputations the pros and cons, and please let the industry explain their situation. I'd like to respond to one point. Well, we'll listen carefully to the points raised by Mr. Chan, and we will liaise with the sector. Well, I'd just like to respond to the point about private hospitals. Mr. Chan said that we have done nothing in terms of regulating private hospitals, and the fees and charges continue to increase, and there is no means to control expenses. Well, we understand that, but why I want to say that this won't happen, Mr. Chan, because by 2020, it will be increased by 40%. And on fees and charges, in order to enhance transparency, we're already discussing with private hospitals. So instead of taking the DRG approach, we also require a high transparency with fee schedules in private hospitals, and we also demand that this be made available in private hospitals so that patients will have an idea of the expenditure involved in mind, and patients can therefore compare prices beforehand, and this can help exert pressure on any increase in fees and charges. And this is also a challenge for the private hospitals, and I've been very frank with the Hong Kong Private Doctors Association that by then there will be keener competition. And right now, because of insufficient transparency, patients cannot really compare prices, but in future they will be able to do so, and by comparison there will be pressure on any price increase. Ms. Alice Mack. Chairman, I agree that by introducing VHIS, we can shorten the waiting time in public hospitals so that the really needy ones can use public healthcare services. However, has the government done any calculations or assessed how the public hospitals can really be helped by introducing VHIS? Well, at the community level, I understand that apart from young people, elderly people are also very interested in the scheme, because many of them haven't been admitted to private hospitals before, and with this scheme they may be able to do so. So how can you offer greater incentives for children of these elderly people to take out insurance policies for their parents? These elderly people may belong to the high-risk group. They may need to pay premium with a loading. Therefore, you need a greater incentive for their supporters to take out insurance for them. So, Secretary, any incentive for children to take out policies for parents? Because many parents of course, will be willing to take out insurance policies for children. Thirdly, it will be pointless if you do not improve regulation of private hospitals. Secretary, now you talked about the regulation of private hospitals over its charges and fees and services. Now what we're concerned is that after introduction of the scheme, more people will be streamed to the private sector, and we wonder if the increase in demand could be met. Well, Secretary said that the hospital beds will be increased in number, but what kind of hospital beds? If only first class wards will have increase in hospital beds, then there is no increase in service capacity. What about operation of private hospitals? You say that DRG won't be implemented. Instead, you can compare the fee schedules, but it's really difficult once you're admitted in a private hospital. You won't really ask about the fees charged by different private hospitals for endoscopy. Well, if I'm sick, I have to be admitted. So how can you really regulate the fees and charges and services of private hospitals? And apart from private hospitals, they day clinics and ambulatory centers, I think the complaints mechanism is not good enough. So you should step up regulation of private hospitals as well as these ambulatory centers. Now, there is general support from the public on the scheme. However, the insurance sector and some other sectors have concerns over the scheme. If you want a smooth implementation, apart from listening to the views of the sectors, you may wish to consider lengthening the transitional period from 1 year to perhaps 2 years, and there should be a dual-track system for people to have more choices, because you're now limiting the choices available to the public. They may need longer time to decide whether to adopt the standard plan or otherwise. Secretary. Thank you, Ms. Ellis-Mack, for your question. Ms. Mack talked about tax concessions for elderly people. Well, I've heard different suggestions, including a tax concession for dependents. A taxpayer may need to support elderly people and children in his household, and therefore we will offer tax concessions to the supporter for taking out insurance policies for the elderly parents as well as children. On the number of hospital beds, there is a concern whether private hospitals will only increase the number of beds in the first-class ward. But I wish to say that once we enhance regulation on private hospitals, the Director of Health's approval is required for a private hospital to increase hospital beds or change their services. So we do have an influence over the private hospital's allocation of beds, and that a reasonable proportion should be maintained. Now, apart from some elective services which private hospitals could provide the fee schedule in advance, of course I cannot require private hospitals to provide a fee schedule for emergency situations which cannot be foreseen. That is why we'd like to have higher transparency in terms of the fee schedule. Before admission, the patient may not know what kind of service he requires, but the fee schedule should provide a very clear idea.
As for the complaints mechanism, we can consider how to enhance it. You mentioned the transitional period. I think that's a rather creative idea. During the consultation period, whatever views we receive, we'll consider them on the whole. Next, Mr. Chen Han-pan. Thank you, Mr. Chairman. Just now, the Secretary, Dr. Koh, mentioned the parent allowance is just $22,000, very little. So if you can provide more incentives, then you'll be able to attract more children or more people to take out insurance for their parents. Of course, the Secretary may say that he doesn't want too many elderly people to take out this insurance. But of course, the major attraction of the VHIS is lifelong protection. I have a few questions here. First of all, about fees and charges. Now the administration mentions $3,600. But what about premium increases? You say the market will decide, but eventually the decision will be made by the insurance companies, and that will reflect on doctors' fees and charges. The Secretary would like to see transparency, but even with transparency, how will it be helpful? The doctor will say, oh, I'm worth this much. If I want me to perform the operation for you, that will be the fee charged. Anyway, the doctor will say that he will charge that much, but very often patients don't look at fees and charges so much. They'd rather have a doctor of their choice. As a result, medical and healthcare expenses will still be very high. Is there an alternative? And then we know that there is this manpower shortage, particularly in recent years. The medical and healthcare sector has experienced manpower shortage. Well, if most patients taking out VHIS are to opt for the private sector, some doctors may want to go to the private sector. As a result, how can we ensure quality in the public sector? Will you discuss with the medical profession and the medical association? Secretary? Concerning the elderly, I believe I've roughly answered that question. If some elderly people or those who maintain them will find this VHIS attractive enough such that health insurance will be taken out for the elderly people. We've not yet set a tax deduction amount or level. But of course, we'll make sure that the incentives are enough. As for fees and charges, you have to consider the insurance companies as well as the private hospitals. For the insurance companies, we won't determine the premium standard for the insurance companies. But as Mr. Chan mentioned just now, by way of the amounts of claims or the claim amounts, as well as the expense loading, we can regulate the insurance companies. Say, of $100 collected, how much will be used for claims? Ever since we started to discuss VHIS, we observed that the discrepancy had been reducing. Well, 63% was mentioned, and then Mr. Chan mentioned 69%. We do see a narrowing trend of that discrepancy. Anyway, we can continue to monitor the expense loading of insurance companies. As for private hospitals, I really have to mention one point to Mr. Chan. In Hong Kong, we cannot determine the fees and charges for private hospitals. Patients, of course, have the right to choose their own doctors. As I mentioned, when everything becomes transparent, if the patient deems a service value for money, say because of the fame of the doctor or the trust of that patient in that doctor, we have to face this issue of market pressure. Even the private medical practitioners have to face market pressure. But the point is, we'll be able to monitor them. For the private hospitals, we'll require them in future to publish certain fees and charges. Then we can work out the median fees and charges. Oh, so the government can only monitor them. The government cannot act on them. Maybe the private hospitals will try to recover their expenses from the patients. Well, Mr. Chan, Hong Kong is a free market. Not even Mr. Chan Kim-po will agree that we should regulate the premium charged by insurance companies. Same for doctors. Say if a doctor has 30 years of experience, then of course he charges a different fee than a fresh medical graduate. As for our work progress, we'll surely regularly report to this panel or subcommittee, and will also enhance training for all types of medical personnel. Together with the Medical Association, we look at examinations, passing rate, internship, and so forth. So for those returning from overseas, the number of practicing doctors here will increase. Next, Mr. Yu Si-wing. Mr. Chairman, the VHIS will be welcomed by the more elderly people as well as the more affordable citizens. So I'm not afraid or worried. But for certain companies, they do offer corporate insurance to their employees. So very often, when a person is covered by corporate insurance and finds himself quite healthy, he may not like to take out another insurance policy. Then, maybe under the VHIS, most patients or members will be above 50 years old. So maybe you can consider adjusting premium. As for the pressure on private hospitals, the government should have good communication with them. And you should also work out with insurance companies a flexible schedule of fees and charges. And then if a patient wants to take out additional health insurance, the standard should be set by the insurance sector. That means we should give more flexibility to the public. So will you discuss with the insurance sector to work out a policy or a framework? Thank you, Mr. Yu. First of all, I agree that as pointed out by some of the deputations just now, the incentives under the VHIS may not be sufficient for young people. We'll offer a choice. We'll ask insurance companies to offer a choice to those employees covered by his employer's insurance. That is, we can set a bottom line such that these young people can opt for VHIS themselves. Otherwise, in future, when they retire, they won't be covered by insurance. So if these young people can shift to VHIS at an early stage from corporate insurance, then their retirement life will be protected. As for incentives, we can adjust our tax concessions. Actually, tax concessions have always been flexible. Every year, colleagues in the Financial Services and the Treasury Bureau will review tax allowances. So the administration does have flexibility here in terms of making adjustments. And I'd like to clarify what standard premium means. I note that some of the deputations here have assumed that the government will directly manage or operate the VHIS. Now, that's not the case. even for the high-risk pool, the government won't be directly operating or managing the VHIS, so there's no question of a standard premium. The premium is for individual insurance companies to propose. I think a number of factors will guard against hefty increases in premium. And of course, we'll discuss with the insurance companies. As regards additional insurance, we're giving huge flexibility to insurance companies. By standard premium, we are only referring to a general ward in a private hospital. If a patient wants to take out additional insurance, he can do so. Say if the patient wants to be upgraded to a private ward, he can work out a plan with the insurance company concerned. And ancillary insurance plans are also allowed. So there's sufficient flexibility here over the standard plan. Next, Mr. Poon Siu Peng.
Thank you, Chairman. I thank deputations for coming and giving us your views. There is general support for the scheme, and for the concerns raised, Secretary already responded to them. Now, I have a question. The successful implementation of the VHIS would very much depend on public acceptance and private hospitals. And we should be mindful about manpower in private hospitals, because as some deputation put it, when this is introduced, there'll be competition for manpower in the public and private sectors. The other have to do with hospital beds, and that should be an increase. Is the government confident that some good results can be seen? Because we need to go through some procedures like legislation. And about high-risk pool, well, there is only a time period of 1 year for those aged 40 or above to choose to convert to VHIS. Well, the Secretary hasn't ruled out the possibility of adjusting this period. And there are already strong views that this should be reviewed so as to provide sustainability for the high-risk pool. I don't know whether at this stage the government has any idea to adjust the time frame. As Mr. Poon put it just now, for Voluntary Health Insurance Scheme, apart from its implementation, the government has to do much more as far as healthcare is concerned. I reiterate that the VHIS is just part of our healthcare reform, not all. And it is only a supplementary program as far as healthcare financing is concerned. We also have other measures to adjust the balance between public and private healthcare sectors. For example, we have a public-private partnership, and that we subsidize patients who use private doctor services so as to ease the public sector's burden. And there are also areas of healthcare reform. For example, we are at the same time consulting the public on regulation of private healthcare facilities. Also, we have a blueprint for a holistic expansion of public hospitals. And earlier, we already reported to the panel the increase in hospital beds in public hospitals to 6,000 to 8,000 hospital beds because of demographic changes in the coming 3 decades. On manpower, we will announce first what we will do to increase manpower for major professionals in the sector, such as doctors, dentists, nurses, so as to prevent high wastage rates in the public healthcare sector. As for hospital authority, we've conducted a review, the report of which will be ready by the middle of this year, to deal with HA's management problems. So there are other issues surrounding the VHIS that we're working on. As for whether we could make adjustments in the future and what the considerations will be. Now, as far as the high-risk pool is concerned, if we change anything in our proposal, then the injection required into the high-risk pool may be different. For example, if we relax the 1-year limit, then depending on by how much it will be relaxed, we may need more injections into the high-risk pool. If we raise the age limit to the age about 40, then again we may need extra injection. Of course, we'll listen to the public's views first, and then we'll ask the actuaries to prepare alternative proposals and then consider the alternatives. Next, Mr. Tan Ka-biu. Thank you, Chairman. I have 2 concerns. I note in the background brief prepared by our Secretariat that for the expense loading for individual insurance, hospital insurance, it is 36%, taking into account profit as well as administrative costs, which is higher than other economic entities. I'd like to know whether there'll be any impact on the VHIS, because comparing to other economic entities, we are on the high side, and we are concerned whether this will become something similar to the MPF. About the $4.3 billion in the high-risk pool, this is the final proposal. What about the remaining $45.7 billion? Different proposals have been made on its use, but we have this impression that Secretary could have all the say on how it should be used. So will there be a platform for discussing the priorities to be accorded as far as allocating the $45.7 billion are concerned? Or will it be a decision made by you only? Secretary, thank you for the question on expense loading. In some jurisdictions, a certain percentage is imposed. We don't intend to impose this limit at this stage. However, we'll continue to monitor the percentage, and if VHIS is implemented, we believe, due to various reasons, there'll be a reduction of this percentage. By how much will this percentage be compressed? Well, as I said when I answered Mr. Chan's question, that according to earlier statistics, the expense loading was as high as 61%. Now it's 69%. That means for the expense loading it's 31%. So we're seeing this trend of compression of expense loading. Do we still have more room? In some jurisdictions, the claim could be as high as 80%. We won't compel this, but we believe with implementation of VHIS, the percentage of expense loading would further decrease. Now, injection into high-risk pool. This is one of the uses of the funds earmarked because this is a risk-sharing measure. Of the $4.3 billion, this is just the amount proposed in a certain year. So you must understand that when it is finally implemented, the amount may be different, maybe more than $4.7 billion. And we still have some $45 billion left. And we mentioned before that some will be reserved for promoting public-private partnership. Although this doesn't come under VHIS, it is another initiative that directly subsidizes patients in using private healthcare services. Thirdly, we have tax concessions to consider. Although this doesn't come under the 50 billion earmarked as well, but we have to take into consideration that it is a form of government subsidy if government revenues is forgone. And there is also a possibility that the $50 billion may not be used up, and this may stay in the public coffers. But please understand that we need to continue to support the development of public hospitals. And you may wish to note that we have public hospital development projects, expansion projects, and new public hospital projects costing even more than this amount. Well, very briefly, Secretary, will there be a platform for a focused discussion on how the 40 billion odd should be allocated, what priorities should be accorded? Well, we're still listening to reviews. We don't have this platform. Next, Mr. Chan Kwok-chi. Thank you, Chairman. Just now, Mr. Chan Kin-po asked about the RG, and the government believes that transparency can resolve all problems. It's hard to say. Even when there is greater transparency, it's another issue whether the public will understand. So whether or not you have DRG or not, will there be a reference price? For example, you can have an annual meeting on the fees for endoscopy and other diagnostic services, and the fee schedules from of private hospitals can allow the public to make comparisons. So I'd like to hear from you on this. Also, the insurance industry also agrees that VHIS can be implemented and they can still make a profit, and yet they also opine that there are a lot of constraints. So my suggestion is to set up something like a social enterprise, which is non-profit making in nature, and that the profit made should be plowed back to use by the public. Then I think the administrative cost could be as low as 15%, not as high as 30%. Next, according to the sector's information, now the administrative costs in a certain year may be 31%, in 2012 it may be 36%. It's done on a yearly basis.
I claim that
In other words, last year he may be claiming 60, but next year the insurance company won't plow that back to the insured. But for social enterprises, they can allow the deposit to roll on, and the beneficiaries will actually benefit. Now we're talking about a social enterprise fully owned by the government. Well, of course, you will mention the intermediaries. We just pay commission to the intermediaries. It doesn't matter for them. They sell the scheme for you, and then they receive commission. You don't need to hire your own frontliners. Many agents will help you. Eventually, the company can operate and have sustainability. At the same time, premium can be plowed back to the pool, and if the pool grows to a certain size, the insured can benefit. Secretary, for a reference standard for fees and charges, you have to consider a baseline figure. Well, let me say this. In fact, even now, Mr. Cheung, you can have some references. Just look at the Gazette and look at the different items of fees and charges under the Hospital Authority. You'll be able to find reference fees and charges. For the Hospital Authority, it calculates the operational costs of public hospitals. That is, if you stay in a private ward in a public hospital, the hospital authority does have a reference fee for you. But if you want to create your own fees and charges, then you have to work out baseline figures first. So I suggest you refer to the hospital authority's schedule of fees and charges for reference. You also propose the setting up of a separate social enterprise to take up this HVIS. But that enterprise will compete directly with existing insurance companies. Strictly speaking, unless the whole society has this consensus of a universal healthcare insurance scheme, under this VHIS, at this stage, I personally have reservation over this proposed social enterprise to set up under the government such that it will compete with private insurance companies. In a moment, the representatives of the insurance sector can speak. The operation of medical insurance in Hong Kong is rather complicated. It's not just medical insurance. When members of the public take out medical insurance from an insurance company, they may actually be pegged to life insurance policies. Anyway, for the time being, I have huge reservation over that proposal. Well, Dr. Koh, can you also require private hospitals to disclose their schedules of fees and charges in past years? Those will also serve as references. Dr. Kwokaki, thank you, Chairman. Thank you, deputations and individuals for coming. First of all, I've no doubt that the Bureau Director would like to do this well for medical and healthcare insurance. You've been in the public and private sectors. But throughout the whole world, no healthcare insurance will serve the public sector only. Now, Mr. Chairman, I think Dr. Koh has put the cart before the horse. Take, for example, the recent flu outbreak. The Secretary refused to admit that the low vaccination rate is one of the causes. Actually, that's one of the reasons why we had to spend so much money on flu patients. Not much is injected into a vaccination program, and we have to spend a lot on our public hospitals. So, primary health care is essential. But that's not mentioned in this report. But somebody will accept the proposals. The insurance companies want to make profits. Whether or not the level of profits is 30%, 35%, or 65%. Now, the insurance sector will be happy. The private doctors will be happy. They'll be making a lot more profits. Now, if we are placing $100 billion on our medical and healthcare system, in future, only 64% of the expenses will be spent on the patients. So we're talking about billions of dollars. Why shouldn't we place the money in members of the public? We shouldn't put the cart before the horse. Now, the scheme will not regulate administrative costs and fees and charges. In Australia and New Zealand, is 13%. In the Netherlands, 7%. Up to this moment, the MPF is still a big farce. It's actually cheating the public. You mentioned self-regulation on the part of the industry. If the industry can regulate itself, we won't end up with the present situation. Let me do some calculation with you. Chairman, you know that in our hospitals, most hospitalized patients, particularly in emergency cases, are above 65 years old. $800 at the moment. In future, in the high-risk pool, that will grow to $30,000. In Hong Kong, how many people can afford $30,000 of healthcare insurance? If they can't afford it, they have to queue up in the public sector. The government spends a lot in public health care. Well, government figures clearly indicate that at the moment, members of the public, through medical insurance or their own savings, spend 50% on their own medical cost. At the moment, we spend 2.5% of our GDP on healthcare service. But in medium developed jurisdictions, it's 7 to 9%. So we're actually reducing healthcare services available to the public. We rather shift our focus to healthcare insurance. So, Secretary, you are successful. Members of the public later know that they'll have to pay tens of thousands of dollars before they can be covered by healthcare insurance after retirement. So all the old age allowance, etc., will be spent on healthcare insurance. So you're heading towards the wrong direction. You should try to improve the public sector. Secretary, Mr. Chairman, I think Dr. Kwok had not entered the conference room when I spoke, so maybe I have to repeat myself. Well, Secretary, I was here just now. Now, voluntary health insurance is just an ancillary scheme. It's not the whole medical reform. we're actually doing a number of tasks concurrently. First of all, we're ever expanding our public hospital services. Dr. Koh mentioned 2.5% of the GDP on 7, 8, or 9% elsewhere in the world. Now, in other jurisdictions, they set a ratio. In Hong Kong, it's 5-odd%. Yes, partly private, partly public. Still, we have to examine in that particular jurisdiction how much is borne by the private sector, how much by the public sector. If you want to compare Hong Kong with other jurisdictions, then you should use 5% as the base percentage for comparison. When you say that for other jurisdictions is as high as 8 to 9%. The resources we spend in Hong Kong on medical and health care are less than those in our counterparts. But overall speaking, we've been providing good services. But that doesn't mean that we should be complacent. Should we invest more in healthcare services? Society will have to discuss. Insurance companies can help the private sector. For the public sector, it really depends on economic growth. Then we'll be able to calculate how much we can inject into public health care. At the moment, 17% of government expenditure is on medical and health care. As for prevention and primary services, or services for the grassroots, I fully agree with the Honourable Member. I must point out that VHIS is only one of the tasks in front of us. And just now, we had representatives from public hospitals. They want to see the government do more in the public sector, either by way of public-private collaboration or by way of workload easing in the public sector. Of course, this is a matter for the government to handle, but that is not all that we are doing. And it's inappropriate to compare this VHIS with MPF, because the MPF is a mandatory scheme and the VHIS is a voluntary scheme. Mr. Chairman, I want him to answer one question. How many people above 65 years old enjoying the high-risk pool will be paying $30,000 in terms of premium? Well, in the consultation document, there are figures. I am not certain we can provide the figure requested by the Honourable Member, that is in relation to those above 65 years old. So you're still not answering my question. I hope that he can open his eyes wide and look at the figures presented by the Federation of Insurers. Don't tell us that the Federation of Insurers is lying. Well, the deputations and individuals have been waiting for a long time. Just now I promised to let them ask supplementary questions. 5 of them are to speak. All right, I'll allow 2 to speak first, to be followed by another 3. Mr. Chen Kim-po has invited supplementary figures from 2 deputations. Mr. Ho, thank you, Chairman. Thank you, Dr. Koh. I've been in an insurance company. Now I'm an intermediary as well as a policy holder. Let me say something about the role of an intermediary. Now we have tens of thousands of intermediaries. How can you attract them to continue to promote healthcare insurance? Take a policy as an example, $4,000, 15%, $600. But don't forget, the intermediaries have to do one thing, dedicated service, 365 days professional service. And all intermediaries must have continuous learning and were monitored by a body.
So 15%, just $600. Is it reasonable? As an intermediary, I don't think they are only engaged in health insurance. They have other insurance products to sell. So it's not money that matters most. Like doctors, they also serve members of the public with their professional skills. Now, without the help of from these dozens of thousands of intermediaries, what should be done? We have sufficient manpower with sufficient knowledge and skills, and I urge Secretary to make the best use of the existing manpower resources available to you. A 15% commission is sufficient to incentivize intermediaries to make use to contribute to the sector with their skills and knowledge. And the expense loading is 31% at the moment. 15% goes to intermediaries. But I want to reiterate and ask you whether the commission is attractive enough. Just like the MPF, this rate of commission is not sufficient. However, this gives them an opportunity to get in touch with the clients they'd like to serve, and by doing so, they could help everyone understand health insurance products better. Since they're competent in selling health insurance products, they could really help promotion of such products through the use of the personal skills and knowledge. Ms. Chan. Well, as far as insurance is concerned, we always put customers first. We attach great importance to customers' choices. Now, for young people, well, sometimes young people tell me that they'd like to take out an insurance policy, but now I say, sorry, nothing is suitable for you because the minimum premium would be $3,600. So it's all a matter of whether we give sufficient choices for our customers. We have over 100,000 insurance policies in Hong Kong, and I believe many of you here are insured as well. And if you only give 1 year's time for policyholders to convert the policies to VHIS, there will be some who will not convert. And many of them might have taken out insurance policies a long time ago, and now they will be penalized if they do not convert. So it's back to the same question, whether we have sufficient choices for customers. Mr. Yu Siwing made a very good point. He asked why we can't make the scheme more flexible so that more choices could be given to customers. I have a question for Secretary. Have you considered this? Existing policies or existing plans can go in parallel with the government's standard plan. And we agree very much that we can improve the existing plans. For example, we can guarantee renewal till 100 years old. We can also allow special conditions to be imposed so that different products can be available for different customers without a minimum charge, so that more people will be attracted to take out voluntary health insurance and to make better use of the private sector's service. Secondly, on quotation. Mr. Chuan Kwok-chi just now mentioned why the government hasn't prepared any reference pricing. In fact, in the Gazette, there is a reference list, but the Gazette notice was published in 2003, and we often refer to it. We don't know how far we are from that reference price now. I think the quickest way for the public to know that there is a reference price in the Gazette notice should be devised to address the problems. And in the 12 minimum requirements proposed by the government, this is good. Every day I receive phone calls from customers asking whether claims can be made and how much would be the amount. And I can only say that the maximum amount is so and so, the sum insured is so and so, but no hospital can tell me or tell you what the fees and charges really are. So we need to have transparency of fees and charges in private hospitals as the consultation document proposes before we can really have quotations available, because we're unable to answer whether this will be the charges and fees will be covered fully. This is what I wish to say. All right, Secretary, your response. I need to respond to a number of points. First of all, I fully agree with Mr. Low that the insurance intermediaries play their professional role in selling health insurance products, and in implementing the VHIS, we will continue to rely on their professionalism in publicity, promotion, and education. And Ms. Elaine Chan just now mentioned a case in which a young person asked her something, and this is really this analogy is really getting popular. And she would have to turn that young person down for the minimum charge is $3,600. And if you check the consultation document, the $3,600 is just the average. If you're talking about a young person, of course this serves as reference only. It's just some $1,400. So let's not be confused that there is only one standard minimum amount of $3,600. Just now, some members and deputations asked whether there will be any transitional arrangement, and we can consider based on the views collected. And yet I want to emphasize that the purpose of introducing VHIS is to address the shortcomings of the existing health insurance policies in Hong Kong, and ultimately we believe all such insurance products should meet certain standards, apart from the two we mentioned. Can more incentives be provided to those that should not be eligible under the scheme? I believe this will be a departure from our principles. In fact, it is already regarded as a buffer that we will be enabling these two groups who are originally ineligible to be covered by insurance. But this is not our major purpose. Our major purpose is to encourage more to take out voluntary health insurance. So tax concessions should only be available to those who take out standard plans. Ms. Chen also mentioned that they will be meeting all our requirements, such as lifetime guarantee and guarantee acceptance for those originally not eligible for insurance. And some may say that they don't require such a high level of protection. But I want to emphasize that by proposing a minimum or basic premium, we are just proposing that a minimum level of protection be given. We're not talking about high level insurance protection. It's not that the claims should be kept at 100,000 per person, and then some members of the public may say that, oh, I only need 50,000 as the cap. That's not the case. We'll also refer to the prevailing market rates when we set out the details later. If you specified a certain cap, then if this cap doesn't really meet the reality of the private sector, then this is unrealistic. However, if you say that in some private hospitals they can offer hospital beds at a charge of just $100 or $2, then that's a different matter. We're talking about a reasonable level. Say for a major operation, if the claims amount is capped at $20,000, and if in the private sector, $20,000 won't get you any major operations at all, then this is not realistic or reasonable. So we need to draw a line where services are really available in the market at this minimum charge. Otherwise, this is not a genuine choice for the insured. As for fees and charges of private hospitals, I already said a number of times that as we legislate on enhanced regulation over private medical facilities, we can fulfill our promise of increasing transparency in fees and charges of private hospitals. Next, Mr. Yun, Mr. Choi, and Ms. Tam. Ms. Tam first. Thank you, Chairman. I thank Secretary for his reply. However, as a labor union, I'd like to point out that there are still some concerns in relation to the group hospital insurance. In this consultation document, group hospital insurance products contain elements of hospitalization and other top-up elements, but we believe there are problems. For example, when an employee switches from one job to another, how should the group hospital insurance be transferred? And if the employee also takes out individual hospital insurance, will there be any clash causing a change in the terms and conditions of the group hospital insurance? These are the concerns of our employees. As for the expense loading, I believe the government has made thorough consideration to try to compress the expense loading so that the fees or the premium paid by policyholders could really be used for hospital admission. Just now, some members suggested some measures There are also suggestions from the insurance sector. We hope that these measures and suggestions can be implemented so as to compress expense loading. Thank you, Chairman. Thank you, Secretary, for your time. On fees and charges by private hospitals, Secretary just now mentioned that reference pricing is available in the Gazette, but ordinary members of the public do not read the Gazette. So a more proactive approach can be taken by the government, perhaps to make it available on the website. The reference price. What should the reference price be for all types of fees and charges in private hospitals?
As regards corporate hospitalization coverage, the Secretary told Mr. Chan that sufficient cover is important, but for corporate insurance, for hospitalization, very often the cover is not enough. Many schemes don't have a voluntary top-up plan for the insured to choose. So the insurance company or the employer may not have that offer. So what about disclosure? If a scheme satisfies the minimum standard, is it the government's suggestion that such had to be provided? But voluntary top-up plans are not required, right? So you have to be strict, you have to do it. And then concerning conversion, let me cite the example of an ordinary employee. If he's covered by corporate insurance, then he doesn't think he needs VHIS. But then there's this threshold of 40 years old. Within a year or 2 years, you can keep to your standard rates. Well, it's optional for the employer. If an employee, after serving for 8 years or 10 years, has to leave upon retirement age, there will be a huge loophole. So you have to fix that bug. Don't think that the employee is covered in terms of hospitalization by corporate insurance. When he leaves the company, he may discover that it's not covered. Mr. Choi? Thank you, Mr. Chairman. Thank you, Dr. Koh. I have 3 suggestions. Well, just now, publicity was mentioned. I don't think the administration has not done enough publicity, which is easy to do. For VHIS, for the professionals like doctors, nurses, physiotherapists, and so forth, they should help promote VHIS, telling the patient the merits of such a scheme. Say drugs may be expensive. And even the Federation of Insurers can help with promotion. Don't just ask the government to do it. The government has many avenues to do publicity and promotion. Secondly, about the high-risk pool, we must have young participants. But we know that when we're young, we seldom had to go to hospital. We usually patronize outpatient clinics only. So VHIS should be extended to outpatient clinics, particularly specialist outpatient clinics. And then don't think that serious illnesses will warrant hospitalization. In some cases, patients only need to go to a day care clinic. So in future, the scheme has to be expanded to outpatient clinics. In future, the need for hospitalization may not be as much as we expect now. Take, for example, I charge $100,000 for an operation. Another doctor charges $80,000. Well, even you know that the other doctor charges $80,000 only, you may not reduce your fee. So you try to create competition among doctors. Say in central building, if a cancer drug is very expensive to the tune of tens of thousands of dollars, you can actually obtain cheaper drugs elsewhere, always. So there will also be competition in terms of drugs and medicine. So operation, hospitalization, and medicine, you have to disclose the fees and charges. Well, two of the speakers just mentioned corporate insurance. How do we define corporate insurance? Not just the insurance taken out by employers for employees. Maybe an insurer suddenly comes out with this new service that so long as there are 10 insured, a corporate plan can be drawn up. And just now you mentioned another point. You want a minimum requirement. What you mean is below that minimum standard, there are no products in the market. That means even if a person has taken out an insurance policy at a very low premium, he may eventually find that useless because a number of things are not covered. So will you try to look into corporate insurance as well? Because we don't want people not to be covered. At the end of the day, will this work? It depends on the figures. If you legislate to regulate corporate insurance as well, then to what extent will premium be increased? Sorry, Mr. Chan Kim-po. I suggested a minimum standard, and the administration adopted my suggestion. Now I'm going a step further. If you regulate corporate insurance as well, then job changing, retirement, etc., as mentioned by the two speakers just now, won't pose any problem. So it all boils down to calculation. So if corporate insurance is also regulated, to what extent will premium be increased? Secretary, to answer your last question, we haven't done any calculation yet. But there are a number of points to note. First of all, in the consultation document, we're referring to insurance taken out by employers for employees. So we won't exempt those so-called corporate insurance offered by insurance companies, like 10 persons can form a corporate plan. Now in Hong Kong, we do not require employers to take out insurance for employees. That's different from what's happening elsewhere in the world. In other jurisdictions, employee insurance is mandatory. We're just providing an extra benefit to employees, which is not essential. As for corporate insurance taken out by employers for employees, apart from hospitalization, there can be other benefits like outpatient services, say how many visits per year. We're not mandatorily requiring employers to do so. Well, to the employers, this is cost. When facing such a choice, the employer may just drop corporate insurance totally. Then that will be the loss on the part of the employee. But with at least some form of insurance on the part of the employer, the employee will at least get something. So on those grounds, we exempt corporate insurance taken out by employers for employees. And what about portability. After listening to your views today, we'll go back and examine it. The consultation document does not require that to be mandatory. And just now a friend raised another point, that is administrative difficulty. I'm not that worried about that, because we're talking about technical difficulties only. The consultation document does not handle technical problems, but we are confident that technical problems can be solved. And by the time when we legislate, we'll concurrently handle technical issues. Any more responses for Mr. Choi's remarks? Oh, yes. For publicity, the government is duty-bound to do publicity. But if everybody helps, then the effect would be better. Will the high-risk pool cover outpatient services? We have to understand that primary services are important. The foreseeability is higher for outpatient services. If an insurance plan stipulates that the insured can visit an outpatient clinic a certain number of times per year, the insurance companies will definitely pass the cost on to the insured. So if you ask me whether that is possible, yes, possible, but cost will rise, premium will rise, because it's more likely for the insured to use outpatient services. But for hospitalization, usually you will only be hospitalized when you are seriously ill. Medicine, yes, we'll definitely consider that. In future, when we regulate the fee structure of private hospitals, we're prepared to require them to set out all the details for every item. Now, I have offered a piece of opinion for you. You don't need to respond to that immediately. I just want you to go back and do some calculation. You said you didn't do the calculation. Some insurance policies cover outpatient services. Some employers do that. But if that is the case, the premium will be 3 times the original. So if you allow for an increased premium, the employers will tell you they're willing to do so. Yes, I understand that in certain cases the premium is 3 times higher if outpatient services are to be covered. All right, insurance provided by an employer to an employee will be exempted. That's what you told us just now. As far as I know, the employer will take out insurance for the family members as well. So you'll be coining a new definition, specifying that's to be for the insurance taken out by employers for the employees. Well, just go back and take a look at this issue. No immediate answer is required. Mr. Vincent Fan, sorry, Mr. Chairman, I was late because I was attending another meeting. Well, maybe the secretary has answered this already. I'm interested in this employer-employee relationship. Take my company as an example. We do take out healthcare insurance for employees. Yes, it's exactly what you described. The employee can visit an outpatient clinic for a certain number of times per year. We're concerned about the quality of employee insurance. Now, our company is already paying a premium under the VHIS, so will the government require an additional premium? Our present proposal is that for corporate insurance taken out by employers for employees will offer an exemption. That means we won't require the hospitalization plan under the corporate insurance policies taken out by employers for employees. Now, those plans can continue. Well, after the implementation of the VHIS, my company provides insurance cover for the employees. And then what about the scheme, VHIS?
So, as per our consultation document, the insurance companies can provide a transitional arrangement for these holders or top-up elements so that, well, after the company takes out group insurance for the employees, the company may decide whether to top up for the employee by taking out additional insurance so as to meet the level required. And the top-up component will also make him meet the requirement for tax concessions. And just now you ask whether the government will in future compel such an option for employees, well, by employers, well, or by insurance companies. Well, we'll consider that. But if insurance companies can provide this top-up element, and if by taking out the top-up element, the individual will be able to meet the level required for tax concession, then this can be done. I have some questions on B and C of your paper. Yeah, we are going to regulate private hospitals, the level of service, the quality, safety, so on and so forth have been discussed by your committee, or have been discussed by the panel. The most important point is whether things can be implemented smoothly. First of all, through legislation in future, the Department of Health will be given even greater regulatory powers because the legislation at present is quite outdated. Only when the Director of Health is satisfied that the private hospital has met the standards required in terms of manpower, facilities, and service quality, can the license be issued. So as long as the three requirements are met, the Director of Health will have to issue licenses. But in future, we have 19 areas of regulation, including complaint mechanism, transparency in fees and charges, service quality, facilities, etc. And private hospitals will also be required to publish as reference fees and charges for previous surgeries and services provided. And they'll also be required to provide quotations for patients for selected procedures. And this will greatly enhance transparency of fees and charges. In terms of collaboration with private hospitals, I can reassure you that I've been working with the Private Hospitals Association, and just now the chairman, Dr. Lee, was also here, and we have been working with them on promoting collaboration, and they also support us in amending the law to step up regulation. Next, Mr. Peter Zhou. Thank you, Chairman. Just now, Secretary mentioned enhancing transparency. I want to point out that, first of all, you all along have been referring to these organizations as private hospitals, but there are privately operated clinics and diagnostic centers providing services like endoscopy and other services. So maybe you should also discuss whether the 19 areas of regulation should also apply to these centers. And secondly, whether by enhancing transparency that can replace DRG. Well, either annually or seasonally, announcements will have to be made. For example, in June every year. And the announcement should be made by the government, not by private hospitals, in order to have real transparency of fees and charges. And just now, Secretary mentioned that if we entrust or if we set up a social enterprise to take charge of that, the government will be competing with the private sector. But in fact, according to the insurance industry, they don't consider this scheme very profitable anyway, and after rolling out the VHIS, some insurance companies may decide to devise their own insurance plans, some tailor-made ones for their customers, instead of joining the VHIS. But I think this can be addressed by enhanced publicity to attract more to join the scheme. I think we could further discuss the issues. You don't have to have reservations so quickly at this stage. Whether the public will trust the commercially run insurance companies or the publicly run social enterprise, that's another matter. It's a matter of whether the service can be provided which is comparable to that provided by the insurance sector. In fact, they can go in hand. I mean, the insurance companies can sell the VHIS as well as their own insurance products. In fact, the members of the public won't suffer any loss if both are available to them. Thank you. In relation to clinics and diagnostic centers undertaking high-risk procedures in the community, I want to say that if doctors in these centers are only responsible for making diagnosis or administering injections, we won't require additional licenses to be issued. If high-risk procedures are undertaken, then they will be required to get extra or an additional license. And I can tell you that we will also require these clinics to disclose their fees and charges for better transparency. And secondly, I have to tell you at this stage, frankly, I don't have this in mind about setting up a social enterprise. Well, I may consider it if no insurance companies are interested, but at this stage, I really don't have this plan in mind. Mr. Chan Kin Po, about group hospital insurance, well, please consider the means of SMEs and whether we will get the contrary result, and that companies will decide not to take out insurance for their employees. Well, for those age 15 to 19, the premium will be 1,500, but that's a figure several years ago, and if we take into account inflation, then by 2017, the figure will be $2,000, and after making adjustments, it could be as high as 2,900. That means if the premium for a 19-year-old is 2,900, then it's not surprising if the premium could be as high as 10,000 for somebody in the middle age. I need to hurry to another meeting soon, but I want to tell Secretary that I know your good intentions. You'd like to help Hong Kong resolve this problem. So please continue to discuss with us. I am 99% okay, so to speak. If it were not for the high premium as the so-called admission charge, I would agree totally with you immediately. Well, I agree with Mr. Chan that for the figures quoted in my example, those figures were formed on the basis of what happened 2 years ago. But I would just want to clarify the point raised by Ms. Chen. I think we still need to follow up on a number of issues. I don't think we'll be able to finish it this time. We need another meeting. The Secretariat has provided another slot, 2:30 to 4:30, the 3rd of March. Not many members are here, and the Secretariat will contact individual members to confirm the slot. So nothing to say on this suggestion, right? If there's nothing under AOB, the meeting's adjourned. Thank you, Secretary. Thank you. Thank you, everyone, for coming to give your views.